Tomorrow belongs to those who prepare for it today. A seed planted today takes root and grows into a tree that bears fruit in the future. Over 110 years ago, a seed was planted. Today, that seed, the idea of excellence, has grown into the University of Pretoria, South Africa's largest contact research-intensive university. 9 faculties and a business school are spread across 7 beautiful campuses, which are home to over 50,000 students, ready to make an impact in the world beyond university and join our global network of nearly 300,000 alumni. Future-focused, sustainably developed facilities and cutting-edge multi- and transdisciplinary research are underpinned by a desire to transform lives and have a positive impact on communities and the world. Excellence in teaching, learning, research innovation, arts and culture, and sports puts us firmly amongst the world's best universities. Knowledge is not just what is in books. It is the wisdom to apply it, to nourish and nurture the seed so that it takes root, grows tall, bears fruit, and branches out. UP plants that seed, that tiny bit of curiosity, creativity, critical thinking, hope, the desire to care, respect, help, and innovate against all odds, to grow, to leave your mark, to excel, to challenge the norm, to think, to rethink, to discover, to inquire, to lead, to have courage, to make a difference, and to persevere. This is the University of Pretoria. We make today and every day matter.
Good day to all our viewers joining us for this discussion, which is planned to be the first of a series on the topic of health economics, especially with regard to feasible applications of recent advances in the biosciences, and especially in third world context. I would especially like to welcome our speakers for the discussion. We will delve into various topics this afternoon with a special word of thanks to Professor Lisa Borman, who put together a splendid program in a remarkably short time. Finally, just a reminder to participants listening in to make use of the chat function and to pose your questions in the Ask a Live question tab. Now, I would like to welcome Professor Burton, well-known professor in biochemistry at the University of Pretoria, where she's also a member of top management. She's associated with UP's Future Africa Institute in campus, who also linked the multidisciplinary Health Economics Discussion Forum endeavor with Future Africa, for which we are very grateful. We believe that her appointment as the first woman president of the Royal Society of South Africa was as groundbreaking as the appointment relatively recently of the First Lady Principal of St Andrews University in Scotland, who ex officio then also became president of the traditional male bastion, the St Andrews Golf Club. Professor Burton. Can you please unmute? Can you please unmute, Stephanie?
Sorry, that was actually not the unmute. Let me start again. So good afternoon, everyone. It is my pleasure to welcome you to this Health Economics Discussion Forum on behalf of the University of Pretoria and Future Africa. I'd particularly like to welcome Professor Alex van der Heever, our guest speaker for the afternoon, and Dr. Mick Forder, who is the CEO of AMPATH, Professor George Gericke, who's a clinical geneticist and who just started the proceedings for us, who is associated both with AMPATH and with UP. And then our panelists, they will be introduced in more detail when we begin the panel discussion, but Dr. Juliet Nyabyanga, Dr. Obina Onwujikwe, and Dr. Jackie Mio, and then Professor Steve Koch, you're all very welcome. And let me also welcome Professor Lisa Boardman, who holds the AMPATH Chair in Human Genetics at the University of Pretoria. And of course, all of you who have joined us from a number of regions in the world. It's a particular pleasure for me to be able to welcome you today for a number of reasons. Firstly, this forum is being established through a collaboration between the University of Pretoria, and in particular the faculties of Health Sciences and Natural and Agricultural Sciences, and AMPATH. In my previous role as the Deputy Vice Chancellor for Research at the university, I was part of the extended discussions and negotiations that resulted in the establishment of this chair, and which is now supported by AMPATH and hosted here at the university. And it's wonderful to see that the activities of the chair have rapidly developed to a point where we can now host an international discussion forum on a topic as important and relevant as health economics. The chair in human genetics was intended to advance collaborative translational research and postgraduate training in medical genomics. So the main aim is to develop research and training programs related to human genetics within the Department of Biochemistry, Genetics and Microbiology in the Faculty of Natural and Agricultural Sciences, and the Department of Genetics in the Faculty of Health Sciences at the university, all in collaboration with AMPATH. The postgraduate training component, which is particularly dear to my heart, will provide a combination of formal training programs with mentoring and supervision of research projects in a field which is especially relevant in current times. And it's good to see that the chair is already linking into the highly relevant area of health economics, bringing the transdisciplinary approach that we all need at the moment in our research activities. And secondly, I'm delighted to be able to welcome you on behalf of Future Africa. You will see at the end of the meeting a video which will show you just how spectacular Future Africa is as a campus. It really is a remarkable place, and we've recently agreed on a collaborative association between the Health Economics Discussion Forum and Future Africa. So this will be an ongoing association. I'm sorry, we aren't actually on the campus at the moment, but as I say, you will see how remarkable it is later. Let me make one or two comments about the relevance of this forum. Although some of you may have heard this before, I often say, Future Africa is a community. It's a research hub, it's a home for scholars, and it is a meeting place, virtual or real. It provides a platform, a physical and intellectual environment for transformation-minded science leaders and innovative business leaders, and policymakers and civil servants and civil society, all to interact and to take science forward towards new development which will come across disciplines and suit cultures and fit our new generations. We see Future Africa as a game changer. Our vision is that Future Africa will transform the world through African research excellence. And it's built on the recognition that finding solutions to today's challenges requires the global and continental science community to operate in a fundamentally new way, focusing on transdisciplinary and interdisciplinary approaches and incorporating teamwork and building academic networks. So bringing together experts from health sciences and economics, and just look at the fields, the different fields of our experts who will speak this afternoon: social security systems, health policy and governance, pharmacoeconomics, and epidemiology, for example. Future Africa has a research theme which we call Health, People and Place. Broadly, we seek to unlock novel capacities to ensure the right to health and well-being by addressing the priority challenges for all of the people in Africa. So, ladies and gentlemen, our quest for developing, understanding, and supporting the intersections and relationships between health research, business and industry needs, and society expectations aligns well with your mission of being a focus group in health economics. Ladies and gentlemen, on behalf of the University of Pretoria and Future Africa, welcome to this event, and I hope that you'll enjoy the afternoon. Thank you.
Thank you, Professor Burton. These are certainly very encouraging words, and we look forward to, in a multidisciplinary fashion, continue with this and see it grow and see how recent advances in the biosciences could benefit all populations in South Africa, because some of the problems require new solutions, and this has, of course, to be evaluated in a health economic fashion, and this is what this is all about. Now I would like to introduce the CEO of AMPATH, Dr. Mick Vorder, who runs this national pathology group with a strong hand on the tiller of the formidable supertanker. As you can see on the program, he seems to be attracted to highly challenging activities, including golf and freshwater fishing. Dr. Vorder.
Thank you very much, George. Appreciate that. So AMPATH is one of the largest private pathology practices in Southern Africa, with a staff complement of over 5,000, of which there are 130 registered pathologists from all disciplines. The service offers over 2,700 different diagnostic analyses and operates 24 hours a day, 7 days a week, with a market penetration of approximately 35% of the pathology market in South Africa. The service comprises more than 300 facilities, including reference laboratories, regional laboratories, satellites, and service depots. We do approximately 85,000 clinical analyses daily. In 2017, AMPATH signed an agreement with the University of Pretoria with a view to exploring cooperation between relevant disciplines based in the faculties of health sciences and natural and agricultural sciences. We agreed to collaborate on jointly co-funded collaborative initiatives from which mutually beneficial projects could be conceived and supported. In 2019, a research chair in human genetics was created, and Professor Lisa Bornman was appointed across the Faculty of Health Sciences and the Faculty of Natural and Agricultural Sciences to drive the Translational Genomics Initiative. Dr. George Gericke, who we've just heard introduce us, is a driving force behind health economics at AMPATH, was recently appointed as extraordinary professor at UP. Health economics was soon identified as a key capacity to build through this collaboration. The Health Economics Discussion Forum at the University of Pretoria is an initiative to forge a transdisciplinary, interinstitutional, academic industry network to support collaboration and inform policy. The pathology industry plays a significant role in healthcare and health systems. We appreciate the insight Professor Alex van den Heever will share regarding the relevance of economic analysis. AMPATH has invested significantly to contribute to better healthcare, and we hope to do so in improved frameworks and policy in the future. I thank you for allowing us to participate. Thank you.
Thank you, Dr. Vorder. In addition to thank Dr. Vorder for setting aside some of his precious time for us, it needs to be mentioned again that Professor Lisa Borman, who arranged the program, is the current incumbent of the chair, which is sponsored by AMPATH, to foster academically driven research and development to benefit not only industry, but the whole spectrum of health needs of our local populations. It's an honor to welcome today's main speaker, Professor Alex van den Heever, who, from what I can gather, is a formidable chess player. Apart from having the good sense to complete his postgraduate studies in economics at UCT, among his other accomplishments as an economist is that he's currently an adjunct professor in the chair, social security systems, administration and management studies within the Wits School of Governance in the Faculty of Commerce, Law and Management at the University of the Witwatersrand. His special fields of expertise include health economics and financing, public finance with a specific emphasis on health policy matters, strategic government policy relating primarily to health and social security, and policy and planning modeling. Professor van Heever served on a large number of the most important committees of recent years. Of special relevance for today is his deep involvement in health economics since 1994. He produced more than 50 key reports in this regard, as well as more than 70 peer-reviewed publications, if I counted correctly. The topic of Professor van Heever's inaugural lecture is the relevance of economic analysis applied to healthcare and health systems, what is needed and what happens if we don't have it. And we look forward to this very much, Professor van Heever.
Thank you very much for that introduction, and thank you for the invitation to present today. And I hope it will be of value to both the listeners and to the university as well. Maybe firstly, just as an introduction to kind of where I've kind of come into the field from. It's important to note that in the 1980s, the sort of late 1980s, when I kind of decided to move into the health economic sphere, there were no other people in South Africa other than one who had any postgraduate qualification in health economics. That at the time was Di McIntyre. And it took a while before we found each other through publications. And it's the idea of health economics has evolved considerably since then. But I think that a large part of what my presentation will go through today is to look at the kinds of issues that health economists should be looking at, and where in fact we are thin on capabilities and skills. And the field of health economics is potentially a lot broader than originally conceived, for instance, in many of the people who kind of built up the field, particularly from the United Kingdom. And I hope to kind of give some sense of that complexity in the field itself, and the implications of not having people with a strategic capability within the health system and to support effectively decision making. I think maybe that, just to begin with that particular point, is that health economics is very much about helping to make better decisions. And the question is, where is that relevant and what kind of analysis is required for that? And I'm going to kind of run through a series of sort of analyses which will potentially show where the problems lie in understanding how we need to improve decision-making in South Africa. And want to shift away from the idea that a lot of health economics is about a very static analysis of options, and much more toward being able to support dynamic decision-making, which is a lot closer to the management and administration of health systems. And I feel that that is where a lot of the system is lacking at this point. So I'll just share the screen. And hopefully that is visible to everybody. So so essentially the topic is the relevance of economic analysis applied to healthcare and health systems, and what is needed and what happens if we don't have it. So health economics is typically being seen as economic evaluation and the sort of the only necessary competency in healthcare. And I think a lot of people in the sort of the biomedical sphere, in pharmaceuticals, are aware, have this as their key focus. But it is not the only focus, and on its own will not solve the decision-making problems within the health system. So the field of economics is actually wide and is broadly divided into sort of what the typical spheres of economics, macroeconomic analyses and microeconomic analyses. So the microeconomic analyses is where a lot of health economics can be seen in, where economic evaluation fits in, which are very specific choices often made by public authorities about whether or not to choose particular commodities within the system based on cost effectiveness criteria, for instance. But a lot of microeconomics also deals with how markets work. And I'm going to bring out that distinction as well, because if our systems of decision making are inefficient, whether they're in the public sector or the private sector, then we're going to have distorted health systems. Macroeconomic analyses and analyses that look at the big picture can be quite important if you're looking at system-wide changes in expenditure, for instance, in health systems. And there it's important to have a very clear understanding about the differences in the kind of fiscal strategies you may pursue if you're looking at that, and as well as on the knock-on effects, multiplier effects, and how to understand them. And it's important to understand that expansions in healthcare, rand for rand, do not have the same impact as, for instance, an expansion in expenditure in, say, social grants. These are very different effects, and they're not very well understood, given a lot of the conversations at that strategic level. And that's largely because we don't really have people examining these issues very concretely in the health policy sphere. So virtually every aspect of healthcare requires economic consideration. So that's might be not a very helpful notion, but in fact the choices at almost every sphere can benefit from coherent economic thinking, and I hope to demonstrate that. So this includes resource allocation frameworks, which is very often what you're looking at in distributing resources. Especially when you're looking at basic packages of services that you're trying to implement uniformly, as well as ensuring fair and equitable access to health systems within a universal coverage framework. But this is not a simple matter. And I will hopefully illustrate that going forward. And South Africa's resource allocation decision-making has been very poor up until now. And we're effectively pooling our resources very inefficiently and not taking advantage of the potential capabilities in our system. And it's also, and that is an area that has clearly not benefited from coherent advice within the system itself. There's also industrial policy. I mean, healthcare is not just a public system, it's an industry. There are multiple industries, and it's actually very important as an industry in and of itself. So quite aside from its public health effects, you also have to analyze it as an industry. And I'll draw on that a bit as well. The social policy aspects, I think, are generally fairly clear. You've got competition policy issues, regulatory frameworks, information frameworks for decision-making, governance frameworks, which actually cover a lot of those previous topics as well. And would fall under the area of institutional economics, and all aspects of public finance. And right now in South Africa, we basically lack people who are properly trained in these fields, advising within at a strategic level within government, and at a strategic level within the purchasing part of the system, provincial governments, district health authority levels, medical schemes. And I would argue that a large part of our private sector are very poorly informed and very poorly incentivized to drive the system toward efficiencies. And this is, again, where understanding the structure of a market-based system is very important to being able to enable it to deliver public value. So I'm going to use examples of various analyses that I've performed at various stages to illustrate an expanded range of economic competencies where they would prove valuable. And so just to point out that the sort of body of work that I've accumulated over time can include sort of peer-reviewed articles and book chapters and so on, but quite a lot of the work has actually been very close to policy, to the sort of the practical space, and attempting to resolve those problems. And I think that this is also an issue that's quite important, is that the fields that tend to stay very bookish and abstracted from the actual systems don't really develop the tools that are necessary and useful for solving problems in our health system. So being closer to decision making is potentially very important for economists looking to solve real world problems and to build these ideas into routine decision making, which I think will be my emphasis here. Just in terms of wider governance as an issue, governance here I'm using not as a corporate governance issue. I'm referring to how an entire system is organized to achieve particular objectives. So we exist in a world with multiple and bewildering overlapping institutional frameworks, which include legislative frameworks, markets, and markets are an important institution, and organizations both subject to legislative frameworks as well as evading legislative frameworks. So this is a very, very complex framework, and health systems are extraordinarily complex. And if you don't really have a very coherent center that is understanding how to create structures that involve decision-making, but within a coherent structural framework, your system will become unbalanced, which is largely what we're seeing in South Africa today. And this is an area which is certainly a large part of that thinking, is both economic, but it is also about governance, and it is also about understanding how to design, how to achieve sort of strategic management objectives subject to these overriding governance frameworks. How do you get incentives to operate in the right direction, and how do you get organizations to institutionalize good performance within them? And we are currently failing pretty much in all of that. And we've also got a private sector that is very efficient at not being efficient, which I think is an important issue to examine. So institutional frameworks always operate with much of our sort of daily lives influenced by what I'd refer to as invisible structures. So this isn't the invisible hand of economics. A lot of what happens to us depends on laws and structures that are both de jure and de facto. In other words, you might have something that's in the law, but there's a practice that's actually more material than what's in the law. How much of that law is actually applied as it was intended? Many legal frameworks are only partially in place. And sometimes if they were fully in place, they would be quite destructive as well. So that's the legal frameworks, but there's also the other structures, concentration, imperfect power distributions within environments, both public and private, that can distort decision-making. And understanding those is very important from an institutional perspective. So much of what we face is too complex to fully process, and yet we must still choose to act. And I include not only the sort of the traditional idea that consumers themselves make irrational decisions because they don't know enough, but also policymakers and strategic decision makers who themselves only ever get access to partial information, sometimes because of their own fault, because they don't design systems that inform them routinely and effectively. And in other cases, it is really because of the constraints of time and complexity. It takes time to build systems to get information that informs you for real-time decision-making, that can ensure that your organizations, whether public or private, improve their decision-making at the margin. So it's therefore important that our systems are progressively improved to sharpen decision-making in real time. So if we had to look at the issue of economic evaluation, which is for many sort of cost effectiveness analyses, cost utility analyses, various attempts to identify what is the most appropriate new technology to introduce into a market or a system at any point in time. And these decisions are sometimes in certain countries embedded and institutionalized into public entities that try to make these decisions in some sort of rational context. But economic evaluations attempt to assess value for money for alternative treatments that are typically static analyses and are only applied to new treatments and assume rational and efficient substitution of high value for low value treatments. And that is a big assumption. If you've got systems that can't differentiate between high value and low value, on a routine basis, your system will be inefficient regardless of any economic evaluation that is being done. You might be substituting out high value for very low value on a routine basis. So the practical reality of health systems, whether insurance-based or what I would refer to as supply-driven, your free public services. So insurance-based systems are typically demand-driven systems, which have their own particular risks and vulnerabilities. And supply-driven systems like a free public service is also driven by a set of incentives that are different, but can be as incoherent, result in as incoherent decisions if you don't understand how to configure these major systems to make efficient decisions on a real-time basis. So substitution, let's say you've got an economic evaluation that has identified a high-value intervention from new technology, should not only look at substituting new treatments in, but you have to have decision-making structures that routinely make decisions for existing technologies and existing products within the system. Now, many health systems just do not have this. They're not routinely reinvestigating their own, what already exists, pre-existing technology and pre-approved technology subject to budget constraints. It's quite a difficult thing to do if you don't really have the system set up, because healthcare is very complex. And you have to have a coherent way of doing this. But if you've got a very, very weak management structure, you will not be able to do any kind of coherent substitution, regardless of what has been produced in any study. So economic evaluations, therefore, don't acknowledge the decision-making inefficiencies in health administrations and insurers. So just to point out that if we've got perverse incentives in insurance markets, so medical scheme administrators in the South African context, if they have perverse incentives of one form or another, their decision-making will not be to substitute out a low value for a high value service or product if it doesn't suit some other objective which might not be value-based. And a lot of these incentives do exist in the current system. So a new innovation comes in that could substantially reduce costs, but it will be an inconvenience for the administrator to introduce it, given some conflict of interest they may have in other parts. And I will talk to that more. If they've got that conflict of interest, they will retain a low value service, not replace it with a high value service, regardless of the new any other new technology coming into the environment. So the important substitution just never happens routinely. And therefore your system becomes systematically inefficient over time. You do not have any convergence on productivity. So potentially more value for money would emerge if strategic decision-making at the management level was made more efficient in real time. So I'm now going to talk to the problems that governments have to solve and this is very much a kind of an economic assessment of the kinds of aspects that inform the role of government in healthcare. And if you had to listen to some of our sort of public statements and public officials, they will talk about healthcare being a public good. And there's no explanation behind that. There's no analysis of what that actually means. In economics, a public good is a form of market failure. It's a particular good to which you cannot apply the exclusion principle, which means that you can't buy and sell it. So it's like a defense force. Healthcare is by definition a private good because you can apply the exclusion principle, but it doesn't mean that you don't have social aspects that you apply to it, social decision-making that are important. So that's an important distinction. We don't really have a coherent discussion in South Africa about what we mean by deciding or how we decide on when government must be involved and when government mustn't be involved. So if we had to ask a series of questions, so excuse these, they might be a little bit small, but so you've got the first question, which would be very pertinent to us today, which is to ask, is the medical condition contagious, highly infectious, transmissible? In other words, does it produce epidemics and pandemics? And if the answer is yes, then everyone has an interest in getting new treatment. So you don't want a private market to create a barrier to access, for instance, to vaccines. You want to make sure that everybody is treated equally. Otherwise, there's going to be a feedback effect on the people who can access something. So this is typically referred to as a merit good argument for government involvement, and suggests a very positive role for government at this level. But it means that government must either subsidize access, regulate for access in private markets, or provide free services. Note that there's more than one option. The idea that government must be involved in some way doesn't mean government is always the producer of the good. Governments are not always the best way to produce certain goods, but they can enable access to things. So for instance, if there is going to be a financial penalty associated with accessing something in the private market, government can subsidize that away. You want to look at the most efficient mechanism for dealing with that particular problem. But let's ask another question. So if the medical condition is not particularly contagious and the answer is no, we can go to the next question, which is, do you have adequate income or assets? And if you've got adequate income and assets, you'll go to the next question. But if you don't have, then the issue is, it depends very much on society's values as to what now gets done. And the tendency has been for people to regard healthcare as being something to which everybody should have access. So that's a social value that has become embedded in pretty much every country in the world except the United States to a degree. So in this instance, government must either subsidize access, regulate access in private markets, or provide free service. Again, government is not necessarily the only producer. Government must look at a mix of options to make sure society has universal access for those who have access, for those who have inadequate incomes or assets. But if you have adequate income, you ask another question. So does the medical condition involve catastrophic expenses? So if it does involve substantial catastrophic expenses, even if you have adequate incomes, you're not going to be able to afford the out-of-pocket expenses of the healthcare concerned. So if the answer is yes, then you're not going to be able to, there's a question as to whether or not you're able to borrow money to pay for that, but you're not going to find credit markets that are going to supply loans to people for 2, 3, 4 million rand healthcare services when you're 23 or 24 and they can't be sure you'll be able to repay the loan over a lifetime, which is what you'd require. So this means that if you want to have access, you will essentially need access to insurance, to health insurance. So the other answer is, does the medical condition involve catastrophic expenses? If the answer is no, you can actually pay for it out of pocket, and the market will resolve the problem. This tends to happen for quite a lot of basic consultations and primary healthcare services. So then you ask the next question. If your answer is no, so you pay for it privately, to access insurance. So now there's a requirement, you have adequate income, but you need health insurance. The next question is, are you young and healthy and have no pre-existing medical conditions? If you are in that condition, then you have temporary access to health insurance provided privately. Temporary because at some point in time, all of these things are going to happen to you. You're going to have a pre-existing medical condition, you're going to get old, you're going to develop comorbidities, and health insurance markets will exclude you from coverage. So the issue is if you don't, so you fall into that category, then it means that you do not have access to privately offered health insurance. You're structurally excluded, even though you had adequate income. So this is a market failure of coverage, which you have to address if you want to have universal coverage for those who have adequate income. So now we go to the situation where you have adequate income and government actually has to intervene. So government must either subsidize access, regulate access in private markets, or provide free services for those people who would be excluded based on their health status, despite the fact that they have adequate incomes. But now you have adequate income, regulated access to health insurance, what could go wrong? So here you have, so the question here is, you can have insured consumers of private healthcare are not price sensitive. Because you've got insurance, insurance becomes a market distortion in and of itself. And so healthcare providers start to supply extra services they shouldn't into this market because people will just pay. They're not subject to individual household constraints. The budget constraint is the pool. And cost of insurance rises faster than incomes. And at some point you have government must basically step in if you want to solve this problem. This form of market failure, you then have to have government step in to regulate and keep private sector costs in check. If you don't, then you're basically going to have people converging on the out-of-pocket market as if they had no adequate income, and they would basically have to make use of other kinds of services. So the issue is this presents is more than one rationale for why government has to be involved in healthcare. And they represent different problems that have to be solved in different ways. This is not necessarily how it's been understood in the South African context. The tendency has been for people to think in terms of what they understand, rather than to actually understand the system and try and introduce solutions to the relevant problem. And I think this is quite important. Again, this is an area that's very important for economists to be able to advise on at a strategic level, because it results in incredibly misguided policies if you do not attempt to look at each of these individual problems and create solutions to them at a systems level. So my approach to a large part of this presentation is to examine the sort of economic analyses required to achieve what I'd call the notion of a basic benefit package in South Africa. It's basically how we would choose what we cover, which is what sort of traditional economic evaluation would be part of trying to do, but is most certainly not the entire solution if a whole lot of other things are missing. I'm going to look at it in both the public and private sectors as an illustration of where health economics can play a role. So the idea of a basic package, I think that I do, in reading white papers and stuff, I think you could get a little bit confused about what this really means. In South Africa, there is typically a failure to understand that the requirements and supporting systems for basic packages differ as between insurance-based and supply-driven health systems. You can achieve basic packages and access to basic packages and universal coverage across an entire system, but where you're combining, when you're dealing with a pluralistic system, which is what we are dealing with, then you have to look at different institutional mechanisms for the private and the public systems. If you don't understand that, then you make a complete mess. There's an assumption I've seen in some analyses by people with health economic qualifications who appear to understand the idea of a basic package as a costing exercise. It is not a costing exercise. It is way, way more than that. It's a combination of an affordability problem and a health system decision-making problem. And both of those issues are can benefit from coherent economic understanding. So the failure to make this distinction has resulted in policymakers reducing discussions to something they can understand rather than trying to understand the problem. There's a difference. In one approach, you immerse yourself in your system and you attempt to gain a fundamental understanding of the issues and problems you're dealing with. And in the other one, you don't bother. You just try and flatten your logic. And what that results in is a very cartoonish approach that never allows you to converge your system on establishing universal basic packages. So South Africa does have what can be referred to as a pluralistic universal health coverage model. That means that we provide universal coverage with more than one system. And we have regulated approaches for our private sector and we have a public system. So across the two, so people talk about NHI, for instance, that they would introduce some sort of mandatory contribution into the system. The reality is we have a mandatory contribution. It's called general taxes. So we already actually pay into a public system and there are pooled funds available within the public system. And some of those funds go towards subsidizing people on medical schemes, as well as paying for public healthcare services in kind. And then you have a regulatory framework that prevents medical schemes from excessively discriminating. And as I'll point out later, it's not complete, but from excessively discriminating against people with if you have an adverse health status. So the idea is to keep people with access to coverage by creating regulatory interventions that ensure people have access to an insurance market. So as I point out in that sort of set of problems that you're dealing with, the problem in the private system is that if you do not regulate for access, it will discriminate against bad risks, and they will be structurally excluded from coverage. And so if you want the private system to be an important part of your universal coverage model, then you have to find a regulatory mechanism that preserves the sustainability of the private system while providing access. So if you don't provide a regulatory framework that does that, you will create structural instability in the insurance system where they are required for survival purposes to exclude people from coverage. They won't be able to compete in an unregulated market on fair principles. They will discriminate structurally against bad risks, and you will not have universal coverage. Plus, they will behave inefficiently, as I indicate. So the important thing is that once this issue has been understood, a basic package implemented in the medical scheme system needs to be designed and operationalized differently to the way in which you would do it in the public sector. But both require context-relevant support systems to deliver public value. And that's what I'm going to try and give an illustration of in some of the analyses that I've certainly done. So let's just begin with the public sector. So if we had to look at the kind of problem we have to solve in the public sector, we can start with a kind of policy which we can frame in general terms as service, a ratio of services to population. How many clinics, how many theaters, how many ambulances, how many services per population do we need? That's a policy, effectively, a strategic policy. It's obviously framed here at a very high level, but it actually in many senses can be reduced to this analytically. But let's look at the number of things you have to get right to get coherence in this. To do this, you also have to have staff to service ratios. So to note that there's staff to population ratios, but staff to service ratio is basically how you staff any kind of subcomponent of the health system. So if you're talking about an ICU, how many shifts do you have and what's your ratio of nurses to patients, for instance? So if it's a 1-to-1 ratio and 2 shifts or 3 shifts, it has a big impact on your overall cost. That ratio determines that how many people per ICU bed, but the policy, the strategic policy is how many of those beds are we going to have per population? The two together need to be understood, but that's not enough. That's affected by your cost of employment. So how many can you afford depends on, you've got an overriding budget constraint, but your cost of employment, your staff to service ratios, and your population to service ratios must be understood. Then you've got your non-staff consumables, and you've got your equipment. So non-staff consumables is where a lot of economic evaluation might fall in. It might take into account some of those staff components, but it won't necessarily have a complete systems understanding of those staff components because a lot of staff time is shared between different protocols and services. Then you have the quality and efficiency of services that are delivered. That also impacts. This is something that's very poor in South Africa in the public sector. There's lots of evidence for that. So once you've got all of that, you've got a kind of unit cost. And if we had to look at the quality and efficiency of service that are delivered, you've also got is related to the quality of the accountability framework that's in place. If this is not in place, you're going to have a perverse effect on quality, which is going to reduce the productivity of the services provided. This depends on the auditability of performance. It also depends on whether or not you've got consequences for non-performance. Well, let's see in South Africa whether we'll have consequences for senior members of the executive who behave badly. Then you take into account the population served. So your unit cost times your population will give you your total cost of your policy package. And then you've got your available budget constraint. So let's look at all the things that complicate this picture. Wage agreements can change everything. If the wage agreements increase faster than your intended service expansions and your population growth, then your services have to fall behind if they are subject to the available budgets. Technological change can impact, depending on the speed with which an organization, a public health organization, can internalize technological change, it might mean that they end up lagging improvements in efficiency over time. But technological change can improve depending on the equipment, and that will also include other kinds of functions that affect the efficiency of healthcare decision-making. Then there's the capacity to efficiently revise policy and manage change on an ongoing basis. Now, this is hugely problematic in the public sector, is that the actual capability to change what you're doing requires immense capability. If it's not there, it doesn't matter what has changed or the information that has changed outside to show productivity, they won't do it if the skills aren't there. Your population served is also affected by net births and deaths, net migration, as well as the needs per person. So obviously, if the burden of disease changes because of a new pandemic or disease, or there is an emerging set of health conditions that arise from lifestyles, all of those aspects change the configuration of need over time. And if you're not on top of that, then you end up with services that are basically not directed at the changing needs. They're directed at the needs of 10, 15 years ago. Then you've got the capacity to fairly manage demand. All health services are subject to rationing, all of them, private and public. If you do not have a way of doing this fairly, then you will do it unfairly, quite obviously. That's pretty much how we do it. I mean, so in the public sector, one of the ways originally of managing HIV and AIDS was to send people home to die. If you look at the statistics under COVID, you will see that enormous numbers of people clearly never made it to public hospitals. When you analyze the excess death information, which isn't acknowledged by the National Department of Health as an adjustment to their reported deaths, excess deaths show that we have about 160 to 180,000 people who've died, not the 50-something thousand that is reported. If you work back from that to infections and potentially to bed activities, we've had many more people who have died without going to a facility, potentially. And unusually, when we look at the statistics that are presented, that the public system in, let's say in Gauteng, saw fewer COVID patients than the private sector, unbelievably, which suggests that either people didn't go to the public sector, didn't reach it, or that they didn't count them. Almost anything is possible. So capacity to fairly manage demand means that you've got to be able to ration in a coherent way, but you don't want to have irrational rationing, which means that you're basically allowing people to die who could be saved and not prioritizing your services efficiently. Then there's the issue of contingent liabilities. What's going to happen that you haven't thought of? Boilers blowing up, Eskom shutting down your water supply indirectly. By all of these things impose potential costs. All sorts of costs are in there, including medical negligence. You've got to be able to internalize that as well. Then you've got technological change that can affect auditability of performance. The better that becomes, the better you can hold people to account. Governance design affects the consequences of performance. Are you actually going to hold somebody to account? Then you've got negotiating capability. This is, to me, one of the big, I see this happening with a lot of provincial administrations. They just don't know how to negotiate for budget. Many of the people within the facilities are so weak in their capability, and this corporate governance designs have resulted in structures in which the key people in key institutions don't know how to budget. They don't know how to argue for money. They don't know how to bid. And if you don't know how to bid in a public sector context, you don't get resources. So sometimes the reason that you have a decline in resources in public administrations is because you don't know who to negotiate with to get budgets. And this is in our multi-level government system requires that you have the capacity to negotiate at a national level as well as at a provincial level. So this is and the negotiating capability is dependent on your governance design. And that governance design also impacts on the capacity to efficiently revise policy and manage change on an ongoing basis. So if these This is everything that needs to be resolved. If we don't have institutional control over these potential variables, don't think you're going to have a coherent basic package that is going to be coherently designed and involves a continuous process of replacement of low value with high value services. So this is our current organization, just very broadly, of our universal coverage model in South Africa. And a large part of what I'll talk to now is just around this issue of, so part of the way in which provinces get their money is from a provincial equitable share allocation. That's what they'll be funding one part of the basic package on. I can guarantee you pretty much nothing of that previous slide is actually being done in any systematic way anywhere in the public health system at the moment. And you've got a system of, so provincial equitable share is in lieu of our fiscal federal framework. And the fiscal federal framework has been implemented in order to devolve it involves attempting to use a democratic governance to induce efficiencies at a lower level of government, in which certain functions have been devolved and subjected them to a political process. And in lieu of taxes, a provincial equitable share is allocated because that's the most efficient way to allocate what would have been the taxes that provinces should have raised on their own. Given that there's a big distortion because they created too many provinces, we've got provinces with very big economies and provinces with very small economies. And the only way to ensure that if they were able to raise their own taxes, to ensure equity of access to taxes between all provinces would have been to have a tax capacity equalization framework. Without that tax capacity equalization framework, Mpumalanga would get a lot fewer resources than Gauteng. So in lieu of having a very tricky to administer tax capacity equalization mechanism, the taxes are raised nationally and allocated down through an unallocated block grant to provinces, but that is in lieu of taxes. That's substituting for them having to raise their own taxes. So that's about 33% of all provincial revenue comes from these two functions. And so between these two, you have to have an organizing framework which must identify and create certain norms and standards that define your basic package that is provided for at a provincial level. If you don't have a coherent framework around this, your basic package will be just whatever the provinces do on a sort of relatively ad hoc basis. And currently, that's pretty much how things work. So, so I'm going to now talk to some of the key elements that are required to organize that basic package more coherently. And this talks to some processes that have been attempted in the past, but I'm going to divide it into two areas. One is about the conditional grant framework to fund to fund the key strategic hospitals in the system, and the other is the whole idea of strategic human resource planning, both key to a basic package. So the elements of a human resource, so this is now the human resource planning framework that's required. And I'm going to sort of define all the elements that should be in place and then talk to what is in place. So theoretically, what you need is a base year, a planned starting point. You need a policy departure point. In other words, a deviation from the baseline. These need to be quantitatively determined. So you need real-time data collection to inform this. Currently, the Department of Health does not collect this. There's data that's available, but they do not routinely collect this information. But you need this real-time data collection framework to inform a base year and establish a baseline. So a base year is your starting point. Your baseline is your policy starting point. Ratios are constant, but population growth means that the policy can stay constant, but the overall expenditure will increase with population, for instance. Then you need to select policy variables and incorporate them within a structured analytical framework to modify this baseline. That potentially is supported by a model, which will determine feasible planning scenarios, which tell you both the cost of your package based on the human resource requirement, and you might have to have a number of important planning sessions which must resolve technical issues, integrated information in real time supported by a modeling framework. You also require some consultation because models are not alone a decision-making framework. That together formulates a strategic plan. This is critical to a basic package. Then you have to have financial allocations that are developed to support the plans, because if you do not have levers within the public finance framework to implement your plan, you have no plan. Then you have to monitor and implement and ensure the conditions are met, and look at deviations, learn from them. Out of that, your subsidy framework will activate the entire plan. You'll monitor and provide feedback to advise on policy restructuring. This is what is required as a framework. If we had to look at what's in place, we don't have that. We don't have that. We don't have any of that, basically. We have a model because I developed a model for the Department of Health. Some of the variables are there for that. But we have there's no policy framework, no engagement to determine any policy parameters. There are no planning sessions. There is no stakeholder consultation. So basically, this structure, there is no strategic plan, even if they're published. So even if a strategic plan based on the model is published, which is sometimes done, there is no strategic plan. Importantly, there are no levers to implement a strategic plan, even if you had one. And you have no monitoring framework. The monitoring framework, for instance, would be that if you're allocating a large part of the human resource modeling framework says we have to resolve the problems of an undersupply or an underproduction of health professionals by subsidizing education and subsidizing healthcare platforms to train more professionals. And we would do this at an individual level. That means that subsidy frameworks have to be activated, in which if provinces and universities do not comply with the requirements of the strategy, that they do not then receive the funding, the subsidies that would go with that. If so, that's basically how you activate the strategies. We do have some allocations in place, but they are not connected to a strategic policy framework. So there's no subsidy framework that activates the plan. So I'm going to indicate the kinds of analyses that are done without a lot of the levers that are in place. So the policy frameworks have actually been developed, in which you basically create. This is for the Department of Health, the modeling framework that's been developed for them, in which the complete framework hasn't been implemented, but the analytical framework is in place. But the important thing with modeling, which is where economists, again, can provide a great deal of support, is to allow for integrated decision-making, to take complicated decisions, not complex decisions, complicated decisions, and make them simpler to make for decision makers. And when you integrate various data and information sources, you can actually make relatively complicated decisions easier to make in a meeting. You reduce it to that. So this is an issue where you would have, for instance, scenarios that you develop based on changes in staff to population ratios, based on a baseline set of information that you'd have. This is for all health professionals. It's just a snip of the overall type of model and worksheet. Something like that would then feed information into a planner for every single health professional in South Africa. And you'd be able to feed this into a modeling framework, which will give you a target achievement over a period of time and also show where you might be overshooting on your scenarios. And you can also analyze this in relation to fiscal space and budget constraints. So quite a lot of information is then integrated, very complex policy-related information to health professionals, baselines, base years baselines, policy scenarios, 15-year strategies, and your budget constraints based on actual costs within the system. And what I'm showing you here is an analytical framework that can basically be modified in conversation within a meeting. So this would give you also, this basically also feeds in to the different subsidy frameworks. So it tells you how much you'd have to subsidize of the costs of the different staff to create them. So this is the teaching and research platform. the service platform. That's where people are taught on the health service platform, or public hospital. Your teaching, your cost for clinical supervision, and your teaching and research cost total. So the teaching and research cost and clinical supervision costs would really be for the teaching platform. So these subsidies in combination would give you your total cost of your strategy for funding a particular set of, to ensure that we are producing the right number of professionals at the right time. And you can modify the strategy on a rolling basis every year or every 2 years. So that gives you the human resources type strategy framework. And the whole point about it is that you want to reduce the time taken to make complicated decisions. It would not be possible to analyze all of these decisions and integrate that thinking in a coherent, in a real-time basis for normal policymakers without these analytical frameworks. So the next framework I'm going to talk about now relates to a service plan, basic benefit basically for hospital services and what's required to make decisions there in a public setting. So here,
recording in progress.
I won't go into that in too much depth, just too much detail. And you might have now a target, a benchmark, and your now scenario is basically developing your baseline. Where do you start from? All analyses has to have a coherent baseline. You estimate where we are now in terms of the actual distribution of hospital services. You have to bring in your staff costs, your actual population, and you also have to take into account referral patterns. So Groote Hospital or Pretoria Academic Hospital receive patients from outside of Gauteng, and the referral pattern creates a configuration of hospital services that respond to the actual people that need to come to it based on their catchment populations. Currently, there is no formal framework in place that actually matches the hospital configuration to the catchment populations, which is what you have to do if you're planning coherently. So this modeling framework has actually been developed. And what it will do, for instance, is analyze, and I'm only showing you a snip of it, cost center structures for norms planners, which really look at your staff to service ratios for every single possible service in a hospital facility. So this looks at the administrative structures. This looks at your cost centers around the clinical services. The green areas are planners that are active. In other words, that's where we actually have services. The red are redundant capability in the modeling for services that we don't have. So we might have complex and interventional cardiology, and we've got a T1, T2, T3 option, which is tertiary 1, tertiary 2, tertiary 3. Tertiary 1 is a provincial tertiary service. Tertiary 2 is a supra-regional tertiary service. In other words, other provinces come. And T3 is a national service, of which your catchment population is the national population. So this shows you a spread across these different services. And then it shows you the data type within the modeling framework, the unit of cost, and a potential planning size that you're using in the modeling framework. When you go into it, there's an individual planner for every single one of these cost centers, which basically drives it. It's difficult to see. It's difficult to get it to the right size, but essentially what's happening here is when you're planning the norms for a service, you basically choose based on the occupational specific dispensation categorization of hospital staff in the public sector. You choose the category and you choose the ratio to the bed unit or the service unit that you're using. And that will give you a staff cost out of that. And you've got here the non-staff cost component, which is based on costing studies, which gives you a distribution of cost to staff costs. Without going into it in too much detail, if you do not have this baseline information, you cannot plan your package. It's not possible. But this framework allows you, when you run it through a modeling framework, to produce both your human resource requirement as well as your financial requirement. And you can analyze it within catchment in relation to catchment populations. You'd also have a way in which you can match your services to potential demand. I won't go into it in too much depth, but based on a catchment population, you derive a number of bed days, which you run through any model. So it's important when you actually look at this analysis to relate it to catchment populations. So it's very important to be able to relate the modeling framework to very specific catchment populations. This just gives you a picture, the way the model has to filter the services that are available. And so this shows for all these hospitals, Nelson Mandela, Frere Hospital, Livingston Hospital, etc., for every single regional or tertiary hospital in South Africa, a configuration of service units. There's a modeling framework in which you can run the scenarios against every single hospital. You can cost the baseline, and then you can run scenarios against potential strategies. So this would be, say, Frere Hospital. This is just a snippet of the available information on the Frere Hospital, just cut off at forensic psychiatry. And you've got the bed type, you've got the number of units, and you've got the type of platform, academic or basic. So if it's academic, then you're going to bring it into a higher cost structure because it's part of an academic platform. But if it's not academic, at the basic cost, the difference between the two will be important in terms of how you subsidize that hospital. And the way the modeling framework works is you can modify the configuration of this hospital, and in 15 minutes, you've got a new plan for the hospital, which would be impossible to have done in the past. You'd take months and months to be able to reconfigure an entire health system. With this type of modeling framework, you do it in a morning. So just to give you an example of aggregate outcomes, this has been run for the entire health system in the public sector. So what you're able to do is to say here that R stands for a regional level service, nephrology, basic, not academic. We were spending maybe a total cost of 6 million on that particular service and a unit cost of 351,000 per person. So you can do this for any service, the full service configuration. Here's anesthetics. Here would be the cost for the different types of anesthetics that we'd have, either regional, the D stands for district level, T1, T2, T2, and you've got the different amounts we're spending. So nationally, we were spending, say, 347 million on theatre units at a basic level at a regional hospital level. And so on and so forth. This is the management tier, and you can see how much we would be spending based on the modeling framework. And this allows you to run the model against the actual expenditures, and this was recalibrated against actuals in the BAS system. So that's the public sector. And now all I've done is given a sort of a very, very quick indication of the prerequisites for designing a basic package in the public sector in such a way that you could practically tie it into public sector decision making. But now there's the problem of the private sector. So, so let's look at, I'd indicated the market failure problem in the private sector. A potential market failure problem, which is that costs rise when you have an insured market. So various public policy documents have been published in South Africa and elsewhere that kind of oversimplify the contracting inefficiencies or the solutions to them in insurance markets. So for instance, there's a common thing that fee-for-service is inefficient and it should be replaced with capitation. That is such an oversimplification of the problem. The problem is that fee-for-service is a result of a system. You want to get a different result, you have to modify the system. It's not about creating a different way of contracting through diktat. So it really doesn't help to say fee-for-service is inefficient. How is it inefficient? And what do you have to do to get the market to converge on more efficient decision-making, more efficient contracting? Currently, the entire market is driven toward highly inefficient decisions, atomizing providers, creating supplier-induced demand, etc. So we're dealing with multiple actors in an extraordinarily complex set of markets that intersect very imperfectly. We've got market power, which in and of itself is distributed, and power, which in and of itself is distributed unevenly between the actors and final users in the system. You have to solve that problem before you're going to get an effect on the system. So the conventional approaches have been, let's look at administered prices. Let's just flatten it all. Let's just say we introduce a regulatory framework that says this is what the fee will be. But the dynamics of cost and quality are too complex for administered price approaches. These are useless. in solving, if you want markets to be an important institution, which they can be and are in many countries, an important institution in delivering universal coverage, then you have to basically reconfigure the system. Our costs are at a very superficial level are determined by price and volume. So activities, and the volume is basically of activities or products. But the value-based choices involve price, volume, and quality, not just price and volume. Now, our current system can't really, our private system, and very definitely not our public system, neither can actually determine and use the market to differentiate quality. In other words, to create a convergence on value. Just to point out the nature of the problem, in spot markets, these three elements, price, volume, and quality, are united in the purchase decision. When I choose to buy a cell phone, even if I don't know how to program an app, I have a reasonable sense of the quality of that particular product relative to a competitor. And that competitor can include the old cell phone in my pocket. It's also competing with the second-hand market. But the moment I make a purchase decision, I've signaled the suppliers. The demand decision, based on a qualitative assessment of that product and its price, actually sends a signal back. And so in spot markets, these three elements are united in that decision. But in insured markets for healthcare, these three become separated. They become three independent decisions, perverting the signals. Prices are determined by fee-for-service negotiations, which are unrelated to demand. And nobody knows quality. Nobody makes any decision based on quality. So it's a highly inefficient, it's a market that is clearly failing under those circumstances and will become severely distorted. So some aspects of quality and some aspects of efficiency might come into the system, but essentially it is structurally distorted at the market margin. So the naive solution is to assume that markets as an institution cannot be used effectively to achieve public value. This is the dumb solution to come to from what I'm just saying. The reality is that if you want to use the institution of markets, you then have to look very carefully at the system and make it work for you. So standard solutions, administered prices, also distort signals to suppliers. They can't solve volume and demand and quality considerations. Administration, so you put a lid on price increases, what do providers do? They increase volume. If the financial incentive is there, they're protecting incomes, they're protecting basic revenue streams. They don't change their revenue streams, they just modify what they can modify, and they can modify demand. That's what supplier-induced demand is all about. They make the final demand decision for consumers in a healthcare market and an insurance setting. And where the consumers are basically insulated from the cost of that decision, they don't care. So you've got a market where if somebody needs to double up their consultations, they just make sure people come back for an additional consultation. They get more products that are given to them. They introduce all sorts of other ways of raising revenue. Then you can introduce capitation, which is, oh, well, we'll pay you a flat amount regardless of the amount, regardless of the demand you see. Well, that internalizes historical price and volume inefficiencies, because I'll tell you, you go into a capitation negotiation in the private sector, forget it. You're not going to get a cheaper price than what you were paying under fee for service. So wherever you start, you're going to be paying that price. You're going to have just internalized the cost, the historical cost. And then they then have an incentive to reduce quality and to reduce demand. So you've got these effects that if you can't manage them, you don't have a competent system to manage them, forget it. You're actually causing healthcare value added to drop. You can introduce DRGs, diagnostic-related groupers, for the reimbursement of hospitals. But this tends to over-aggregate price and volume, creates risk selection incentives. So where your DRG is not properly rewarding for a particular service, in other words, for a particular set of severity of risk, the sort of severity of the cases, so you're getting a lot of severe cases, what they will tend to do is to try and bump off all the severe cases. So they'll also tend to reprioritize within a hospital towards where they're getting most revenue from the DRG. So DRG systems do not necessarily induce efficiencies or value for money. They're also an oversimplification on their own. Global budgets, which is how we finance public hospitals, also on their own cannot internalize price, volume, and quality because they can't control quality unless they have major governance systems in place to manage that. That's why the public system is so weak at the moment.
I'm sorry, Professor van der Heever, we are bound by
we have specialized
severe time
regulatory
constraints.
frameworks, such as
Professor
the
van der
Competition
Heever.
Act. And I'm going to talk now, this is again talking with an eye on what economists do. We have this sort of field in economics, industrial organization, which tend to be people who want to go and sit in the competition.
Professor van der Heever.
And make money.
I'm sorry, we're bound by severe time constraints. May I ask you to perhaps wrap up in the next 5 minutes?
The issue here is that there's a very simplistic understanding of competition, typically in the Competition Act, which when you're dealing with a complex industry like healthcare just falls apart. They just don't know how to analyze it. And the economists tend to be pretty weak on that because all they've ever done is the traditional industrial organization assessments. And yet the context is so different to what they're analyzing. So essentially, you cannot apply generic analytical approaches to complex sectors. And actually, it's not only healthcare. So analyzing price elasticities for parking lots can't be used to understand market dynamics in highly evolved sectors that are subject to sort of complex arrays of market power and forms of coordinated conduct, when in fact the understandings of market power are in fact quite, are themselves quite naive in some cases. So in competition analysis, market structure is principally understood as market concentration and the accumulation of market power through the accumulation of market share. So market power, that's the institutional issue they worry about. But in reality, it's far more complex. And in reality, regulatory frameworks also provide the structure which you have to address, but that is not really what the Competition Act deals with. So the problem is that our tools for dealing with weaknesses and market failure through the Competition Act don't really help healthcare. So I'm now going to give you an idea of why. And this is from work that I've done as well, and part of the work in the health market inquiry, which is part of. So if we had a look at the market dynamics, this is the problem that we have in healthcare, is that a market conventionally relies on an informed consumer. If you don't have an informed consumer, they can't make choices. If they can't make rational choices, the market fails. So the problem in healthcare is you've got consumers that are dependent on, it's a very complex market, both in accessing healthcare services and in accessing healthcare coverage through insurance. So you've got the consumer sitting here, and they have imperfect information of what to purchase in the health insurance side. And therefore, to deal with that asymmetry of information, you have advisors. These are brokers. In the case of accessing healthcare, you're often going through general practitioners at the first level of service, but other service providers. Now, in both of these cases, it means that demand for either product is determined by an advisory framework, not by knowing, independent understanding of these markets. And what's happened in these markets is that the key advisory structures are largely captured by the people who want to sell you the products, which is a natural consequence of any badly regulated market. The moment the market complexity rises above a little bit, advisors come in, and obviously the people who are dependent on the demand of those advisors immediately try and capture them. So we then have medical schemes, health insurance that's regulated. We have third-party administration. We have third-party managed care. Then we have less regulated, this is not regulated for the market failures of access to healthcare, health insurance, and we have financing sector holding companies. And these holding companies own the third-party administrators, the managed care companies, the brokers, and the health insurers, and they also have relationships into the hospital services as well as other parts of the private sector. So they have these vertical relationships. So these vertical relationships, which involve and are principally dependent on these captured consumers, distort the market. So if we had to look at how the market basically looks, this comes from the health market inquiry. this just shows how a set of vertical relationships on the funding side and the provider side has set up complex outcomes for the system. So we look at a holding company structure like Remgro, owns 42% of Mediclinic at the time of this. And Remgro also owns 30.3% of RMI holdings, it would be RMH now. And they own 25% of Discovery Limited, that holding company structure, and 25% of what's now MMH, Metropolitan Momentum Holdings. So these are meant to be competitors, these two here. And under these holding company structures, you have the administrators, you have the brokers, you have primary care coordinators, basically managed care companies, etc. And you have their wellness companies. Discovery, Discovery Health, Discovery Insure, Discovery Life, Discovery Invest, Discovery Vitality, and Discovery Health is actually also registered as a broker and a managed care company. So, but importantly here is that you have a 42% holding of Mediclinic, which means that in this corporate structure, you have the biggest hospital groups in the system, which essentially means at a strategic level, everybody has an interest in preserving each other. So these vertical relationships constitute a very significant portion of the total market. Then we have another big player, which is Afrocentric. So Afrocentric owns Pharmacy Direct, wholesalers in pharmacy and medical products. And you've got Afrocentric Health, which owns administrator, Aid for AIDS, managed care companies, etc., IT solutions, and distribution services. So basically they are vertically integrated into the pharmaceutical environment. And so if we had to look at the problem that potentially represents, okay, I'll finish very soon, so I'll wind up. So if we had to look at the problem that gets created, if we had to break these down into market shares, using the medical schemes information, here's the Remgro construct in 2005 and the Afrocentric conglomerates structure. And you see how you have the market share changing quite considerably between 2005 and 2019. So this is a market where concentration is increasing massively. And there are these vertical relationships, which suggests significant inefficiencies. Because of the time constraints, just to point out that actually analyzing the system is quite complex. You've got to deal with anti-selection, imperfect information as problems, supplier-induced demand, government failure, weaknesses in the regulatory framework, public services as a market constraint, etc., and market concentration of administrations and hospital services, which have concentrated significantly. And by the way, when you look at profit margins, the administrators actually get higher profit margins than the private hospital groups. You've got various forms of vertical and horizontal coordination between the different players. So it's a very imperfect market. One of the supplier-induced demand effects that we have in the system is that in the private sector on critical care beds, we actually have more critical care beds in the private sector than in the public sector as a whole. 2,260 in the public sector, 3,780. This is a largely and a disproportion in, say, Gauteng and the Western Cape. This is strongly indicative of supplier-induced demand. So instead of having a price increase, you actually increase the beds that actually have the highest requirement for reimbursement, the highest cost. So you don't have to increase a price to increase your revenue. You actually increase demand for a very expensive service that it's very difficult to modify. So I'm very short on time, so I'm just going to go through very quickly a key issue that has to be solved in the system, and one of the solutions that has also been looked at is if we had to look at market dynamics in the system and where solutions go, if you've got that split
Professor
between...
Van Heever,
yes, sorry.
I apologize, but we're severely constrained by time. And could you perhaps wrap up, even though it's very interesting at this stage, in the next 2 minutes?
Okay, I will do that. I will do that. So in essence, the problem that has to be solved ultimately is that if we've got to solve the problem of relinking price and demand and quality on purchaser-driven contracts, you've also got to do the same at the consumer-driven level. Solutions potential, this is where our system is, the red area. That's basically most 99% of our system. And what we would be needing to do is to basically incentivize the system to shift toward the green areas. And the important issue is setting up a framework in which we contain the price increases and allow for renegotiation of prices through multilateral negotiations. And this is, I can't discuss it here in too much depth, but there is a framework, again, and taking into account economic logic, in which multilateral negotiations will result in an efficient pricing framework for the fee-for-service component of prices, creating an incentive for contracting to shift toward bilateral contracts and purchaser-driven efficient contracts. What I'll do is finish at this point. Sorry, it won't go into the other areas. So I'll leave it there, but I hope what I've done is just give an idea of the range of issues that need to be taken into account from an economic perspective in a health system in both public and private sectors. And if we don't really get a handle on these and have the capabilities within the health economics sphere, we are actually not going to be able to control our health systems effectively. I'll leave it there.
Thank you very much, Professor van der Heever, for outlining a much more complex scenario than most of us, I guess, have an appreciation for. When we continue now, a reminder to pose your questions in the Ask a Live question tab, which we will deal with later. We now come to the section where various experts have kindly agreed to add further short, insightful responses to Professor van der Heever's presentation. They are Dr. Juliet Nabiyonga Orem, who works for the World Health Organization as a medical officer in charge of health policies, strategies, and governance. Dr. Ubina Emmanuel Onwuyeke is a Nigerian medical doctor who serves as a professor of health economics and policy and pharmacoeconomics in the Department of Health Administration and Management and Pharmacology and Therapeutics at the College of Medicine, University of Nigeria. Dr. Jackie Miot is a division director at the Health Economics and Epidemiology Research Office at the Wits Health University Consortium, with extensive experience in Africa as well as locally. And Professor Steve Koch, head of the Department of Economics at the University of Pretoria, with a broad field of interest spanning energy economics, development economics, and econometrics, in addition to health economics. May I ask the speakers to strictly adhere to your respective allocated 5-minute input times, and if you have comments or questions for Professor van der Heever, can we ask you to also keep this to the section which is open for general discussion. We will give priority to your questions, of course. Thank you very much. The first speaker can now begin. We will start with Dr. Jackie Miot.
It's lower down on the list, but I'm happy to go here. So I think that what Alex has done is really kind of highlighted to us how incredibly complex this situation is of providing healthcare, and it goes so much further than just being involved in the healthcare environment like the Department of Health and so on. I should make a disclaimer or an admission right now is I'm actually a pharmacologist, and I only really picked up my health economics knowledge through doing various certificate courses many years ago, and learned along the way. And it was only because I had this interest in health economics that I pursued it. And I think that's often how people do get into this field. I have taught on many, many different courses, but lots of similar to things like the MPH and so on, where the majority of the students that I teach are clinicians. Occasionally we teach, modelers or biostatisticians. Every now and then there's an engineer thrown in. But principally, none of them have this kind of broader economics background, which, as I've gone through the years of working as a health economist, I realize how incredibly important it is, because when we're doing economic evaluation, which is really what I teach, so it's, how cost effective is one medicine against another, you miss so much of that bigger picture. And in fact, what Alex has reminded me of today is, even when I think I'm looking at the bigger picture, there's an even bigger picture that you still have to take into consideration. And so I look at something, for example, that we're starting to touch on is like antimicrobial stewardship and the problem of antimicrobial resistance. And it's not just about implementing stewardship programs where you want to prescribe, a narrow spectrum antibiotic against a broad spectrum antibiotic, or you want to do certain lab tests in order to prevent unnecessary prescribing. It goes so much bigger than that. It goes to national mass media campaigns and what the impact of that is and what they're going to cost. It goes to legislative frameworks, particularly with the animal health side of things, which really does need a major overhaul in that respect. It goes then even into things like the teaching curriculums at the medical schools, because we need to be teaching doctors better how to prescribe. And that's a whole universe in and of itself. And so on. It goes out to environmental hygiene and making sure that we've got good quality water, making sure that we've got robust systems to look at things like food-based contamination. And we all know what happened with listeriosis some years ago. So these are really go so much further than just, as I said, the Department of Health. It brings in all sorts of different departments, but many stakeholders and many, many moving parts, and a lot of them with vested interests. And so you have to be incredibly careful about how you navigate your way through this. And the temptation, and I know this comes as, within the microeconomic sphere, is to simplify things and is to assume certain positions, which when you dig a bit deeper are not necessarily that. But I also do feel that one needs these kind of cross-cutting collaborations. So it's not just about a microeconomist working with a macroeconomist, it's about working with people who are in other departments and, things like the engineers, for example, the scientists, the biostatisticians. It's all part of a much bigger picture where you can't do it all on your own. And I've said that to my students many times, is that you can't do health economics as a solitary pursuit. You have to do it as a team. And you bring different perspectives into that team if you open it up to different disciplines. I've always thought that, microeconomists or health economists are clinicians who learn the economics along the way, and macroeconomics or health economics are economists who kind of pick up the clinical and health stuff along the way. But I think that's also, again, simplifying it a little too much. And I am looking forward to the Health Economics Discussion Forum, moving on and seeing where this goes and how we can bring in other disciplines to really never solve, but to maybe dig a little deeper into what is a very complex problem. So I think I'll stop there and hand over to the next person. Thanks.
Thank you, Jackie, very much for that insight. Is Dr. Juliet Nabiyonga available? We will ask Professor Steve Koch for his input.
Thank you. All right, so let me just say a couple of things about what Alex did and what I really liked about what he did. He did what I expected him to do, which is, in some sense, remind me a little bit about why I don't always stick to health economics, because sometimes it hurts my head a little bit. But he did remind us, I think, very nicely that in particular, economics applied to health is a very wide field. What I really liked about a number of things he did in particular was, and even relating back to Jackie's comments, he he brought a bit of an engineering mindset to this, a number of flowcharts to at least point out where many of the potential problems are in the sector, where many of the analyses need to take place. And of course, most importantly, which is difficult for many macroeconomists like myself, is to not just separate the problem, where you are located within that problem set from the rest of the set. And I think, Alex always does a very nice job of pointing out these sorts of complications, reminding us that even though we might have an answer in one dimension, that doesn't mean that that answer is actually particularly correct, given the fact that many of the assumptions we've made are very unlikely to hold, and then he proceeds to provide us with some reasons why they don't hold. It's a very useful, detailed analysis of a number of features within the system that I really enjoy. And I think I've been asked also to try to say a little bit about how we might move forward, I think more broadly within this forum. And I think what I'd like to then try to suggest is that we try to take this systems thinking and get more involvement from, in particular, engineers who do think this way a little bit more differently from economists in particular, to remind us of how we can put together broader systems thinking, because we are wanting to take this not just to take the economics to the health side of things, we also want to have other thinking involved. But I'd like to end by thanking Alex. I think that was a very insightful presentation, very helpful, very clarifying, despite the fact that he reminded us how complicated it really is. But the clarifications around what we need to think about was just very well done. Thank you, Alex.
Thank you very much, Steve. I've been informed Dr. Onyenekwa is offline, so we will proceed with the live questions. And I think this one is for Steve. We have participants from the World Bank. What role could funding organizations play in ensuring adequate frameworks and policies in low and middle income countries they support?
That's a very good question. So I think, again, borrowing from a number of things that Alex brought up, one of the areas where we struggle quite a bit, and I don't think this is just the case in South Africa, I think it's very true in many other developing countries, the importance of collecting as much as possible real-time or some version of real-time data that can be used for understanding what's actually happening on the ground. Without that sort of data, it's virtually impossible for us to figure out where problems might be and where we might want to try to at least begin to target interventions. So I think it's very important to start at a fairly basic level. Let's start to help these systems become systems with an information process, if you will, that we can begin to look at. I'm sure there are other things that they can do to help that would be incredibly beneficial. But I think without information, the rest of it is guesswork. And if you guess wrong, I'm not convinced that would be any better.
Thank you. I think the next question is for Alex, but please correct me if I'm wrong. The question goes like this. You wrote a chapter for Child Gauge in 2016 on pregnancy maternal support. Are you aware of any cost-benefit analysis for non-invasive prenatal genetic screening?
So, yeah, so that is directed at me. the analysis doesn't extend to that. It doesn't look at the prior screening. It fundamentally focused on the financial support to the mother in a high risk period, and really looked at the sort of social efficiencies that are going to result if you properly support people from the period of pregnancy and into the first 2 to 3 years of the child's life, and that there are many social inefficiencies that you reduce. So it's largely focused on the impact on the mothers themselves and on the children. The two dynamics are quite actually distinct in that there are mental health effects on the mother, and the mental health of the mother has an impact on the child, and so they kind of interrelate. So that's essentially the point of that analysis, but it was also not a full economic analysis, very much in the sort of costing sphere, which typically happens with sort of social grant evaluations. I don't know if that helps.
Yeah, thank you. The next question I think maybe for you as well. How does South Africa compare to other low and middle income countries in terms of public health expenditure as a share of total health expenditure? We don't have your sound. We don't have sound.
There we go. No, it was not letting me unmute. Yeah, so South Africa's overall expenditure is very high compared to peer countries as a percentage of GDP. And to some extent that is because of the private sector's expenditure, which is very high and unusual in the international context. However, South Africa tracks its private sector expenditure much more efficiently than many of its peer countries. And that I'm aware of because I was part of setting up the system which tracks their expenditure. So their reporting system, electronic reporting system, quarterly reporting system, annual reporting system is all online since about 2005. And as a consequence, there's actually very good concurrent information on the system at a great level of detail. So many other health systems don't collect information like that, which means they underestimate the expenditure on their private sectors. But our public sector is definitely in comparison to peer countries is pretty high as well, at over 4% of GDP. So overall the amount we spend is pretty much where we should be. The efficiencies of our expenditure in both public and private are clearly problematic. And that is suggested by our health outcomes when compared, such as, for instance, proxy indicators like maternal mortality ratios, facility-based maternal mortality ratios. Compared to our peer countries, we are way higher, which means that we are very inefficient in what we do with the amount of resources that we're spending.
I'm not sure whether I understand the next question. I would perhaps think that Steve might be of assistance with regards to financial resource and allocation. What would be the view of using other health professionals, such as animal health professionals, to help share resources and skills, as well as resource allocation? Mick would like to.
I will admit that I'm not quite sure how to answer that either. I think, Alex, you want to try something? I mean,
I'll clarify that. I mean, look, a large part of the discussion in the sort of efficient distribution of human resources in the public and in the health system involves scopes of practice. And so it's not necessarily a question as to whether you want a vet to act as a doctor. It's often a question as to whether or not you want a nurse to do some of the things that a doctor is doing, and whether you want a pediatrician to stop doing some of the things that a GP could do. And very often the restriction in the system is professional qualifications. So the scopes of practice are defined through the Health Professions Council, and there's often a lot of vested interest lobbying around maintaining scopes of practice, because certainly in the billing professions, it affects your income. So the strategic issue really is a part of that health framework, that human resources framework that I indicated would have involved addressing scopes of practice as part of its negotiation and discussion, as part of a strategic way forward. It's one of the ways in which you change your efficiencies, noting that in South Africa, the costs of our medical professionals are probably double that of our peer countries. And therefore, because of the high unit costs, our ability to achieve the same staff ratios is compromised. So that means we have to look at a more efficient use of our other health professionals.
I think this is the last question we will be able to fit in, and this is to Alex as well. Given the broader systemic overview and how complicated, overwhelming it is, how can we go forward in motivating for improving decision-making around the uptake and implementation of new technology or interventions that are not currently being offered in South Africa? For example, here we have it again, newborn screening or non-invasive pregnancy testing in the state system.
So I think one of the, so this is, if you had to look at it as a general economic problem, a key issue that differentiates countries is their ability to efficiently absorb new technology. And this is our weakest part of our health system, is it inefficiently absorbs new technology in the wrong areas and with the wrong incentives. So it does require that one looks at the systems which are required to make these decisions. And we often have very centralized decision-making structures, which can often create gatekeepers to this, who are often subject to vested interest lobbying. So the issue of efficient absorption of technology depends on the systems which examine that and introduce that technology into the system. The best way of doing that is to decentralize a large part of our system, so that these decisions are actually made at the different level of the health system, and that you improve the ability of people to make decisions to bring this in. But also the evaluative side becomes important. But if we improperly incentivize the decision makers, then what they will do is make decisions in the medical scheme side. I'll prefer marketing over actually changing anything in productivity on the system. And in the public sector, if you're not getting a kickback, you won't do anything. And lots of kickbacks in the private sector too. So I think it's around looking at the governance of the overall arrangement and getting that structure right. And it will probably structurally change our absorption capability. We're very far, and by the way, that relates to what one would look at in the rest of Africa, and like the funding institutions like World Bank and so on, is that there isn't a very fundamental focus on governance arrangements, which are critical to decision-making around the absorption of technology and better decisions. But these are very often subject to political constraints in different environments, which is often why funding organizations steer clear of them.
Well, then I would like to thank Professor Alex van der Heever and all the panelists, and ask Professor Steve Koch to have a last word before I close the meeting.
Thanks again. Thanks for managing the session today, George. Thanks again to Alex and to all our presenters as well. I think this was an excellent kickoff to our health economics forum. I think it's discussion forum, sorry, I should use the correct wording. We do hope that this becomes a stronger feature, that we include more people as well outside the country as well as inside the country. We can focus on very specific issues and so on. This is a great way to, I've already said, it's a great way to get it kicked off. But what we're trying to accomplish is to get people thinking about, I suppose, first of all, how economics can be used in fields that maybe people don't think it's being used in, as well as how we can do a better job of getting economics to help us do better in a variety of places. And in particular, Alex spent quite a bit of time today talking about incentives, which is something that economists talk about over and over again. We can lead the horse to water, but we can't make it drink unless it's thirsty and it's nice water, right? So we need the right mechanisms to make the things happen, which means for also that we need to have a discussion around what we actually think is the right thing to happen. Because if we don't also clarify those sorts of things, we aren't going to have a clear distinction about what the appropriate incentives might even be. So I'd like to thank, again, Alex, for bringing out all of the different angles and ideas and concerns that permeate the discussion around how you build an appropriate health system, where we can find the inefficiencies, which is quite simply everywhere, and how we might at least begin to think about matching up the incentives from one set of agents in the system to another set of agents, which at the end of the day are the people using the system. So this is the beginning of, I hope, a number of these conversations, a number of these presentations, where we bring out different aspects around health economics, where it can be used, how it gets used, and maybe even talk to some macro economists, health economists, and again, give people a very strong idea of this the potential for interdisciplinary kind of thought processes and developments. Thanks again, and hopefully we'll see you again soon.
Mick, would you like to say a few words at this stage?
George, thanks very much. I think from our aspect, obviously a highly complex situation, and not being in any way economically, in fact, I'm very economically challenged in trying to run my own personal budget, let alone a big organization, that this is a complex field, and it's very nice to meet a number of the players, and I hope these discussions will continue, as Professor Koch has intimated. But thank you very much for the opportunity for Empath to be part of this. We appreciate it. Thank you.
Well, thank you, Mick and Steve, all participants. Also the use of the facilities here at Future Africa and professional assistance by Louis Kluter Productions. We trust that you've enjoyed today's discussion and look forward to welcoming you at our next forum meeting in about 3 months' time, which is exactly about one of the comments that Alex made near the end of his last comment, was that to introduce new technologies which may be cost-effective if examined properly. And this session will be specifically devoted next time to human genetics and genomics. Thank you and goodbye.
As part of the University of Pretoria, the Future Africa Institute and Campus has established a vibrant, collaborative space that provides access to the benefits of interdisciplinary and transdisciplinary research for the leading young minds of tomorrow.
Future Africa has been created at University of Pretoria to respond to a unique requirement of the African development, which is the adequation between research and daily social transformation. Transdisciplinarity means collaboration, and to get collaboration we need a space to do this interaction.
Our globally sustainable infrastructure and world-class facilities have created a resident scientist scholarly community that works collectively to bring growth and transformation. Through innovative methods, we combine the knowledge of researchers through Pan-African networks that extend beyond disciplines and geopolitical boundaries. The environment we have created thus develops young scientists in transdisciplinary research and science leadership committed to creating an impact in our communities. In aligning with UP's focus on the Sustainable Development Goals, we have based our approach on several themes. These focus on connecting the people of Africa, developing sustainable food systems, ensuring the health and well-being of African communities, empowering individuals through transformative education opportunities, and ensuring equity as well as sustainability in a global Africa. It is Future Africa's unique platform that allows us to continue setting the standard for transforming the world through African research excellence.